All attendees are in listen-only mode.
Good afternoon, everybody. Welcome to Fight CRC's What You Need to Know About Biomarker Campaign webinar. We're super excited to have Dr. Chris Lieu joining us today. Just a quick reminder for everyone who is joining in that Fight CRC has a plethora of resources available, and one of those are to be able to ask questions and all throughout the course of the webinar. Next slide. So we want to just remind everyone that we do have the opportunity for everyone on the right side of your screen to go ahead and key in questions as they come up, and lovely Sharon will be moderating after Dr. Lieu's presentation today. So quick note, just again, the archived webinars live on the Fight CRC site, as well as following along on social media for updates regarding today's webinar to follow along with helpful hints and insight. Quick note, and thank you to Michael Sola, who is always the man behind the curtain, doing amazing things for the technology and for all of the great leadership, as well as Danielle Burgess and Andrew Wortman for their work, and the new intern, Elizabeth, who is actually working to do a lot of great things with social media and coverage for all of Fight CRC's fantastic work. Next slide. So again, just a quick note, if you can find on the right side of the panel, the webinar technology will add you specifically, if you key in questions there, you can, on the right hand side, you'll see the control panel and the orange arrow. And just reminding that you have the streaming opportunity, that if you have any audio issues or the like, just go ahead and join via phone if your computer's not working. And if there's anything pertinent that we should hear, just give us some real-time feedback on that webinar technology chat feature. Next slide. So today is super exciting in that Dr. Lieu has been a champion for biomarker testing and has done a lot of outstanding work here at the University of Colorado. But Dr. Lieu and others have really helped inform a fantastic resource that's known as the Biomarked campaign. And so this is actually the cover that you're seeing is in honor of Clint Cummings, who is a tattoo artist, who is also a colorectal cancer survivor who spread the good word about colorectal cancer initiatives and biomarker testing. But it's really interesting because even though Clint actually passed away a couple of months ago, he did a really interesting connection with him and his team in terms of really showing that compliment about tagging, looking at tattoos and biomarking, and really looking at the synergies in parallel. So we're really excited for a really interesting and hip campaign that's actually been supported through Fight CRC and industry partners, but a great resource in terms of the biomarker testing mini magazine that's available right now. In addition to the late stage trial finder that's also been launched in the last 6 months and has gotten a lot of great attention from Newsweek, with all the great work from Dr. Tom Marcillier, as well as the Fight CRC team, and a number of the research advocates who are helping really make sure that that tool is curated. So just a couple really great resources where biomarkers are central. Knowing your biomarkers is essential for good care and linkage, and these two resources can be definite resources and benefits for your search and for anything that Fight CRC can help in terms of making the match. Next slide. Just a quick reminder that today's webinar is really meant to actually be education to support decision-making and general guidance, but this, of course, is in no way a replacement for direct medical care. A reminder that you need to call 911 in any type of emergent situation, and always get in touch about your personal specific needs related to your own health care. And just a quick heads up, Dr. Lieu and the team will not be able to address individual level medical questions today during the course of the webinar, but we will general questions and information, but we hope that we'll use that biomarker testing mini mag as well as other resources to help make the discussion an open discussion with clinical decision makers. Next slide. So Dr. Lieu is actually a colleague of mine here at the University of Colorado, working in the GI oncology program. And he's a great mentor. He's a great team leader. He's also a great resource for a number of our research advocates, as well as a very beloved physician from his patients. And so we're really excited as assistant professor that he's going to be joining us today. And I would have to say that Dr. Lieu has done outstanding work, particularly also in the arena of the under 50 population in terms of really understanding more about specific disease orientation as it relates to young people as well as older folks. But I think the cornerstone of a lot of his great work has been around biomarker testing and knowing really the implications for really looking at personalized care. So we're really excited that we have Dr. Lieu joining us today. And Chris, I think we'll have you take it from here.
Awesome. Thank you so much for that kind introduction, Andy. And thank you, everybody, for taking time out of a very busy Monday afternoon to talk about biomarkers for colorectal cancer. This is obviously a very important topic, and over the next 30 minutes, we'll talk about what defines a biomarker and what you need to know. I do want to report out my disclosures, which are listed out on this slide, none of which will be of too much relevance for what we talk about over the next couple of minutes. All right, so what are we going to talk about? We need to talk about what defines a biomarker. And one of the problems with this topic is that there are a lot of nomenclature and terms that people use to basically describe a lot of the same things. So we want to define what a biomarker is. Kind of most importantly, we want to talk about how biomarkers can affect the treatment of colorectal cancer and how that might lead to better personalized care. And we want to talk about some examples of meaningful biomarkers for colorectal cancer. This is an emerging field, and so a lot of the biomarkers that we test for, we didn't even think about testing for even a decade ago. And so this will be kind of a changing field, but I'll give you as much of an up-to-date kind of review of the biomarkers that we test for colorectal cancer over the next several minutes. So just a quick colon cancer at a glance. We certainly know that colon cancer is the second leading cause of cancer-related death in the United States. This is a somewhat unknown fact for as little press as colorectal cancer gets, kind of in the lay press. But on average, a person's risk within the United States is about 1 in 20. But of course, this varies according to somebody's individual risk, namely family history. A majority of the cases do occur in patients that are 50 or older. We know that the incidence of colorectal cancer is actually decreasing across the United States, which is just fantastic news. But we also know, as Andy alluded to earlier, that in the younger than 50 age population, we know that the risk of colorectal cancer is increasing. And certainly a lot of research is starting to happen now in terms of why that might be the case. People with a first-degree relative who has colon cancer has a 2 to 3 times risk of developing the disease, and that's why we always encourage people to know what their family history is. And of course, the most important statistic on this slide, there are currently over 1 million colon cancer survivors in the United States, and that number is continuing to grow, and that is just an absolutely outstanding number. So we know that personalized medicine is advancing, and so when we talk about personalized medicine, we're really trying to individualize medical treatment plans. We want to get away from this one-size-fits-all strategy to treating every cancer that there is. And so we certainly know that steps can be taken to identify patients that may be more likely to benefit or may be at greater risk of side effects from a particular treatment. And so by doing individual biomarker testing on somebody's tumor, we may be able to personalize a treatment plan for a patient that has colorectal cancer. So just a brief note on medical treatment plans. We certainly know that the treatment of any cancer, including colorectal cancer, can include a lot of things, including surgery, radiation therapy, chemotherapy, and targeted therapy. And so one of the take-home points, honestly, from this talk is that because there are multiple ways to treat colorectal cancer, we always want all patients to have a good multidisciplinary team. You want your surgeon talking to your radiation doctor, and you want them to also be talking to the medical oncology doctor. And that way, a team of doctors can be treating your cancer as opposed to simply just one individual. And you want to make sure that those doctors are talking to each other. We certainly know that the mainstay of most treatment for metastatic cancer is chemotherapy, and certainly that is a type of treatment that works by killing rapidly dividing cells. And we believe that this is effective because cancerous cells typically divide more rapidly than other types of cells in our body. Over the last 10 to 20 years, the advent of targeted therapy has certainly kind of made its name known in cancer therapy. And so targeted therapy is a type of cancer treatment that doesn't necessarily work by just killing rapidly dividing cells. It works by targeting specific genes or specific proteins that may be altered in cancer. And so targeted therapy can be used alone and can also be used in combination with chemotherapy. And one of the types of treatment that's really kind of coming of age for several cancers, including colorectal cancer, is of course immunotherapy, where we try to teach the immune system to be able to recognize the cancer, and we'll talk about that shortly as well. So from 1957 to 1997, there is literally just one FDA-approved drug to treat colorectal cancer, and that was 5-fluorouracil. So over 4 decades of research was basically done surrounding one drug. And now there are 14 FDA-approved drugs for colorectal cancer, which is a rapid advance. And all these drugs have actually been approved in basically the last 20 years. And this is a combination of cytotoxic chemotherapy, and those are the first 5 drugs that you see at the top of your slide. And these are, of course, chemotherapy drugs that kill rapidly dividing cells. We've also seen numerous biologic or targeted therapy drugs being approved for the treatment of colorectal cancer. Pretty much all of these drugs are approved in the metastatic setting, so not used in the curative setting where surgeon may take out the cancer, and sometimes we give some chemotherapy afterwards to try and prevent the cancer from coming back. All of these biologic or targeted drugs are used in a metastatic setting. There are several different types of targeted drugs. The 2 on the top are cetuximab and panitumumab, which target epidermal growth factor receptor, or EGFR. There are numerous drugs that target vascular endothelial growth factor, or basically trying to limit blood vessel growth around the cancer in hopes of basically pruning the roots of a tree and hoping that the tree dies. In the same way, trying to prune the blood vessels so that the tumor doesn't have as good of a chance to live. And then, of course, the most recently approved drugs for colorectal cancer include immune-based therapies for a very small subset of patients with metastatic colorectal cancer. And we're going to talk about that because this does require some biomarker testing. What I said before was basically a treatment strategy that's been utilized for cancer treatment for many, many decades, and that is a one-size-fits-all. But we also know that if we take 10 patients with colorectal cancer and we do a mutational analysis of their cancers, we know that we'll probably be dealing with 10 different types of tumors, that they all have different mutational profiles. So even though we may call all 10 patients, the disease that they have, we may call it colorectal cancer, we know that each individual cancer in a person is different. And that's because, of course, we're all exposed to different environmental exposures. We all have different genetics. We all have different things that we've encountered over the course of our lifetime. And therefore, it's not hard to imagine that if we have 10 patients that have colorectal cancer, that we might find 10 literally very different cancers. And so we shouldn't also be surprised when we utilize a one-size-fits-all strategy and treat everybody as if they had the same disease, that we shouldn't be too surprised when we have a patient that responds, like our patient on the left, but then the other 4 patients on this slide don't respond. And what we want to get to certainly is a more personalized, individualized treatment regimen for patients with colorectal cancer. So that brings us to biomarker testing. So what are biomarkers? So biomarkers is short for biological markers, which are biological molecules that are found in the blood, other body fluids or tissues that may be measured to provide information about your tumor. So it's essentially any marker that may give us more additional information about your tumor. And once biomarker testing is done, the results of that test may indicate whether a cell's functioning normally or abnormally. It may provide insight on the likely outcome from the cancer if it's left untreated. And we talk about this in terms of prognosis. And so if a cancer is kind of left to its own devices without any treatment, how aggressive is that cancer going to look? How aggressive is that cancer going to be? Biomarkers, and this is where really we want to focus on, biomarkers may also predict the likelihood of a cancer's response to a specific treatment. And so could we use a biomarker to predict whether a treatment will or will not work? That would be helpful information, because as a physician, I can then maybe give a treatment that may benefit somebody, or I can withhold a treatment because they'll get side effects from that drug, but they won't receive any anti-tumor benefit. That's important information to know. And so this is all based around helping you and your doctor make decisions about your care and what treatment that you may receive. And I put in parentheses CEA because a lot of people who have been diagnosed with colorectal cancer know that we test CEA, which is a blood test that we draw in the lab and then measure in the lab. CEA is probably one of the first ever biomarkers for colorectal cancer and can sometimes help guide us in terms of whether a cancer may have recurred. The CEA may help us determine whether a cancer may be growing or may be shrinking. And that is, of course, one of the biomarkers that we use. But CEA does not tell us anything about what treatments we should or shouldn't be using. It's something that may tell us a little bit more about the disease, but nothing really about the treatment. And so we certainly need better biomarkers, and that's what we're going to talk about. I do want to make a distinction between biomarker testing and genetic testing because these two terms can become kind of intertwined and people kind of use them interchangeably. But I'm going to give you kind of my definition for biomarker testing versus genetic testing. So biomarkers are basically any abnormalities or mutations that are found in the cancer cells that are different than normal cells. So I describe biomarker testing as testing that we essentially do more or less on the tumor. And some of the mutations that we may find in a cancer may be driving that cancer to grow. And so why it's important to know whether these mutations exist is, well, maybe we can choose treatment based on these mutations. And I want to make a distinction between that and genetic testing. Genetic testing oftentimes refers to the genetic sequence of the DNA that we're born with. And so genetic testing is often done off of a blood test. And this is where we sequence the DNA. And this is DNA not from the tumor, but from our cells. And it's important to know that some of the genes, obviously, that we test for when we do genetic testing can be inherited. And so one of the familial syndromes that's most commonly found in colorectal cancer is something called Lynch syndrome. And this is, of course, an example of genetic testing because we know that Lynch syndrome can be passed down across generations. So this is a slide from a program that was actually run in 2015, which I think does a really good, gives a very, very good example of biomarker testing and what we may mean when somebody says, well, you're biomarker positive or biomarker negative. And so if we do biomarker testing on somebody's tumor and we say that they're biomarker positive, oftentimes the person is referring to having a mutated gene, a gene where there's an abnormality. And so that's what we may call biomarker positive. Somebody may say, well, your biomarker turned out to be negative. And if you ever hear the term wild type, it basically means that there is no mutation seen there. And so when somebody says that, well, your gene was wild type, it means that there is no mutation detected, which means that there is no genomic alteration. And so people may call that biomarker negative as opposed to biomarker positive. So some of the genes that we commonly test for patients with metastatic colorectal cancer include two of the genes that we see here. RAS is a gene family that includes two genes that we test for, KRAS and NRAS. About half the patients with metastatic colorectal cancer do have a RAS mutation in their tumor, and about half the patients have RAS wild type, in other words, no mutation. Another mutation that we test for commonly in colorectal cancer is for BRAF. A BRAF mutation is much less common in patients with metastatic colorectal cancer, occurring in only about 5 to 10% of patients with metastatic colorectal cancer. And we're going to talk about the implications of these genes along with others because it may help us personalize the treatment for a patient with metastatic colorectal cancer. So we're going to start with RAS mutations. So what does that mean if a doctor tests your tumor for a gene called RAS and then finds a mutation? And what you're looking at is a clinical trial result, looking back at patients that were treated with a targeted therapy called cetuximab. Now, cetuximab targets a gene called epidermal growth factor receptor, or EGFR. And we know that this drug does save lives in patients with colorectal cancer. And in this study, what they did was randomize patients that had refractory colorectal cancer to cetuximab versus nothing at all. At the time that this study was published in 2008, it was cetuximab had not been FDA approved yet, and so the study was essentially comparing cetuximab versus the best that we could give at that time, which is essentially nothing but just best supportive care alone. And when the researchers went back and looked at the patients that were treated with cetuximab versus nothing at all, what they saw was that all of the benefit of the drug was seen in patients that did not have a RAS mutation. And so what you see on the graph on your left is all the patients, that top line is all the patients that received cetuximab plus best supportive care, and on the bottom line is best supportive care alone. What was so concerning about the results of this study was the right side of the graph. If patients had a mutation in the gene called KRAS, those patients receiving cetuximab did no better than those patients receiving best supportive care alone, which means that if you had a mutation in a gene called KRAS, you were getting all the side effects from a drug, but you were not receiving any of the benefit, which means that patients were probably better off just getting nothing at all because they were getting a drug that was causing side effects, but they weren't actually benefiting from it. So one of the take-home points from this talk is that RAS mutations do predict a lack of benefit to targeted therapy. And that targeted therapy that we're talking about here are cetuximab and panitumumab. They are EGFR inhibitors. And so one of the reasons why we test for this mutation is that we can prevent patients from getting a drug that they won't benefit from. So that's one of the take-home points in regards to biomarker testing. We also know that patients with BRAF mutated colorectal cancer, and again, this represents a minority of patients with colorectal cancer, but BRAF mutations exist in about 5 to 10% of all patients that have colorectal cancer. And we know that when patients have BRAF mutations in their colorectal cancer, that the cancer has a tendency to be more aggressive. And we talk about this in terms of prognosis. It means that the cancer can be a little bit more aggressive than what we would normally see. So why is it important that we test for BRAF? Well, there's actually a clinical trial that was reported by Dr. Kopetz at this last ASCO annual meeting this year in Chicago, where he was able to show that the combination of 2 targeted therapies and chemotherapy was much better than a targeted therapy and chemotherapy, just the 2 of them, cetuximab and irinotecan alone. And so why this is important is because if we know that a patient has a BRAF mutation in their colorectal cancer, we may be able to provide them a better treatment option than what is considered standard of care. And so in this case, in the trial that Dr. Kopetz presented, the 2 targeted therapies, vemurafenib and cetuximab in combination with chemotherapy, prevented the cancer from growing almost 2-fold better than just 1 targeted agent and chemotherapy alone. And so another take-home point, RAF mutations may signify a more aggressive cancer behavior, but, and this is an important but since we're talking about colorectal cancer, clinical trials do show promising treatment options. And this is one of the reasons why we test for this mutation is because we may be able to offer patients a clinical trial which may offer better progression-free survival, better time that it takes for the cancer to actually grow. All right, I'll touch a little bit on PIK3CA mutations. This is a mutation that we don't typically test for kind of in a general setting, but it's one that most academic centers do test for. I just want to make you guys aware that with PIK3CA mutations, there has been association with having this mutation in colorectal cancer and actually benefiting from aspirin in the curative setting. So if you have stage 1, 2, or 3 colorectal cancer and you test positive for this mutation called PIK3CA, this is in about 1/5 of all patients with colorectal cancer. It seemed like looking back at patients that had this mutation and took aspirin, that they almost had a 90% reduced risk of having the cancer come back, which is an absolutely amazing benefit seen with a drug that costs essentially less than a penny a day. So if you have stage 1, 2, or 3 colorectal cancer, you've had that cancer removed, and you have this mutation, taking a baby aspirin a day appear to have tremendous benefit. But if you were wild type PIK3CA, those patients did not seem to benefit from aspirin use. So this other take-home point, aspirin may help prevent recurrence of colorectal cancer in patients with PIK3CA mutations. So another example of a biomarker that we may test for that can really affect in a tremendous way how you might prevent cancer in the future. All right, so in this day and age of incredible mutation testing and testing for hundreds of mutations on a tumor, can just having a cancer develop on the right side or the left side of the colon truly be a biomarker? And I bring this up because this has actually been looked at as a biomarker. So I'm showing you kind of results from a large study done in the United States where basically 1,000 patients were treated with different targeted therapies in the frontline setting for metastatic colorectal cancer. But of course, they had several patients that developed cancer on the left side, about 68% of those patients, and about 27% of the patients developed cancer on the right side. And so could even the side of the colon that a cancer develops on affect how that cancer may respond to targeted therapy? And the answer is a resounding yes. So what this study showed that patients with right-sided colon cancer did not benefit from treatment with a targeted therapy. And in this case, it was an EGFR inhibitor. This is even if the patients were RAS wild type. Remember, this is the RAS biomarker that tells us the patients that may be able to get benefit from cetuximab or the EGFR inhibitor. But what we know is that even if those patients were RAS wild type, in other words, maybe they will benefit from this targeted therapy, that the side of the colon that the cancer developed on actually affected whether or not these patients would derive benefit from it. So if you had a cancer that developed on the left and you received chemotherapy and this targeted therapy, you seem to get a lot of benefit from it. But if you had a cancer that developed on the right and you received chemotherapy with this targeted therapy, you did not receive benefit. So it's amazing that even in this day and age of all this molecular testing, that the side on which the cancer develops in the colon can and does make a difference. And so we actually now incorporate what side the cancer developed on when we start formulating treatment plans for patients. All right, so we'll wrap up with one final topic. And so it seems like if the 2000 to 2010 was the decade of targeted therapy, which is a lot of what we've talked about, 2010 to about now is truly the advent of immune therapy. And so we know that one of the hallmarks of cancer is its ability to evade your immune system. You have something that shouldn't be there. Your immune system should be able to recognize it and should be able to fight it and kill it, which is exactly what we would want the body to do. But that's one of the hallmarks of cancer. It's able to evade immune destruction. We know that there are several receptors and ligands that are important in terms of preventing our immune system from fighting cancer. And so what you're seeing here is a graphic of a T cell, which is essentially one of our kind of workhorses for the immune system, and you're seeing the tumor cell on the right. And what you're seeing is that the T cell has something called a ligand, essentially kind of like something that sticks out of it, called PD-1, or programmed death receptor 1. The tumor cell has learned to be able to express a receptor called PD-L1. And so what you're seeing on that top part of that slide is that when PD-1 and PD-L1 make a connection, that's a stop sign for your immune system. It's the tumor's way of being able to tell the T cell or your immune cell, I've got to turn off. I'm not supposed to kill this tumor cell. Well, what if we were able to develop a drug, and this is what's happened over the last several years, that could block this connection from ever being made? So if we could have an antibody that could bind up all that ligand that the T cell has, could we turn off that signaling and therefore get the T cell to be able to recognize the tumor cell and kill it? And so what you're seeing on the bottom part of that graph is essentially a drug that has blocked that connection from ever being made. The T cell is now activated. It's starting to fight the cancer for us. We know that there are several cancers that have more mutations compared to other cancers. So a typical colorectal cancer may have 30 to 50 mutations per tumor. We know that sun-exposed melanoma and lung cancer actually have a higher mutational burden compared to colorectal cancer. So they have many more mutations than what we would typically see in a typical colorectal cancer. What we know is that when we've tried these immune-based therapies on cancers that have high mutational burdens, that have a ton of mutations, that we can get some pretty dramatic results. What you're seeing is a drug, an immune therapy drug, in a patient that has widely metastatic melanoma, a skin cancer. And what you're seeing on the top part of the slide is a heart, and you can see a big mass kind of coming off of the heart, and hopefully you guys can see my pointer, but I'm pointing to this tumor that kind of sits on top of the heart. In the liver, you're also seeing this really large dark spot in the liver here on the bottom part of your slide. And after just a couple of doses of this immune-based therapy, you're seeing almost complete disappearance of that tumor in the heart, and you're seeing almost complete disappearance of that tumor in the liver. In lung cancer, we've seen similar results with this immune-based therapy where we try to activate the immune system to fight the cancer. Here you have a tumor in the lung right here in a former smoker. And after a couple of doses of this immune-based therapy, you can actually see this tumor just melt away from slide to slide, and that's denoted by the red arrow. So how does that relate to colorectal cancer? Say that's great for melanoma, that's great for lung cancer. What about colorectal cancer? So there is a subset of colorectal cancer that has a high mutational burden. And we denote that by saying MSI-high colorectal cancer, which essentially stands for microsatellite instability high colorectal cancer. And we're going to talk about what exactly that is. So over the course of our normal day, our body's tasked with replicating DNA so that our cells can divide and we can continue to regenerate blood cells and make sure our organs are in good function. But just like any type of kind of transcribing of any document, your body does make typos whenever it's trying to duplicate DNA. The analogy that I like to use is that if I asked you to transcribe War and Peace on Microsoft Word, and you had to do that without the help of a spell checker, you would have a ton of typos. And so even when your body has the ability to replicate its DNA, when there are mistakes that are made, it has to be able to recognize the mistake, unwind the DNA, kind of replace the base pair so that the mistake is then corrected, and then wind the DNA back up. Just like a spell checker would identify spelling errors, repair the spelling error, and then you're kind of back on your way to transcribing War and Peace. So if I asked you to transcribe War and Peace with Microsoft Word and a spell check, you might make a couple of mistakes here and there, but they'd at least be limited. But if I asked you to transcribe War and Peace without the use of a spell checker, you'd have, if you're anything like me, you'd have thousands and thousands of typos. And this is what happens in the body when the body lacks the ability to repair mismatches in its DNA. So there are a couple of ways that this can happen in colorectal cancer. One of the most common ways that it happens from a hereditary standpoint is in Lynch syndrome. So what is Lynch syndrome? Well, Lynch syndrome is a syndrome that's genetic, that's hereditary, that's associated with higher rates of colorectal cancer. You also get an increased lifetime risk for other cancers like endometrial cancer, stomach or ovarian cancer. But what Lynch syndrome is essentially the body's inability to repair DNA mismatches. And when that happens, you're more likely to develop cancers, and those cancers have a high mutational burden. There are a ton of typos. You can also have this in the tumor itself. So you can have MSI-high colorectal cancer and not have Lynch syndrome. In fact, a majority of MSI-high colorectal cancer is not Lynch syndrome. It's actually something that happens in the tumor, where the tumor, not the body itself, but the tumor lacks the ability to repair DNA mismatches. And that's called acquired MSI. And there are a couple different ways to test for MSI-high colorectal cancer, and this is commonly done, again, across the nation. Why is that important? MSI-high tumors have many more mutations than traditional colorectal cancer. So typical colorectal cancer, again, has 30 to 50 mutations. In MSI-high colorectal cancer, you're looking at over 1,500 mutations. Well, why is that important? MSI-high cancers have a high mutational burden. They have a ton of mutations, which makes these cells really weird. They look weird to your body because, again, they're so deranged. And why that's important is because there are T cells, immune cells, which start to infiltrate the cancer. They're just not activated. So they're there, they're at the party, they just don't know to activate, to get going. So what if we used a drug, an immune-based therapy that could activate those T cells? This slide that I'm showing you right now shows that, again, this is a minority of patients with stage 4 colorectal cancer. It's only about 4 to 5% of patients with stage 4 colorectal cancer. But in those 4 to 5% of patients with MSI-high metastatic colorectal cancer, you treat them with a drug like pembrolizumab, which is an anti-PD-1 drug, which tries to stimulate the T cell to recognize the cancer and get it going. You can see some pretty amazing responses. So this was a study that was published in the New England Journal of Medicine in 2015, where patients with MSI-high colorectal cancer had a disease control rate of 92%, unbelievably high. These are patients that were basically out of treatment options. And compare that to the other 95% of colorectal cancer, where there was about a 0% response rate and only a 16% disease control rate. looking at kind of how some of these tumors did. On this graph, if you have lines that go up, it means that the tumors are growing. If you have lines that go down, it means the tumors are shrinking. What you're seeing here is that all the benefit was seen at MSI-high colorectal cancer, with some of these patients actually having a complete response. In other words, their tumors completely went to zero in terms of measuring them from a radiographic standpoint. And so there are some pretty amazing responses to this immune-based therapy. And for that reason, the FDA in May of 2017 did grant accelerated approval to pembrolizumab for actually all MSI-high cancers, but this included MSI-high colorectal cancer. Nivolumab also received, which is a sister drug to pembrolizumab, also received FDA approval several weeks ago. So kind of the final take-home point, MSI-high colorectal cancer may predict benefit from immune-based therapy, and some of the results are certainly pretty remarkable. Again, this is in a minority of patients with metastatic colorectal cancer, but a very, very important minority nonetheless. All right, and so we're basically going to wrap up. One of my big take-home messages for this entire talk is essentially just to speak with your doctor. I hope kind of going through some of the data in terms of why we use these biomarkers has been helpful in terms of how it might personalize your treatment for metastatic colorectal cancer. It's important to understand that every patient's mutational makeup of his or her tumor is unique. And with that uniqueness, can we exploit some of the mutations that we find to better personalize treatment for a person's cancer? So knowing your biomarker status may help you and your doctor select an appropriate treatment plan. And I always encourage my patients. I want to empower all of you, patients, family members, caregivers, friends, just people who are interested in colorectal cancer. Talk to your doctor about biomarker testing. And you may ask, well, what should I ask? It's as simple as this. Has my tumor been tested for biomarkers? Yes or no? If the answer is yes, you want to ask, well, how is that biomarker status going to affect my individual treatment plan? If the answer is no, just ask, well, when will my tumor be tested for biomarkers? And what I really want is just basically all patients to have a conversation with their doctor about this. You know, doctors a lot of times have busy practices. There are a lot of things that are going on. You just don't want to, you want to make sure that things don't get left behind the cracks or in between the cracks. And you just want to make sure that every possible advantage has been given to you in terms of personalizing your treatment where you can have the best outcome and the best possible treatment plan available. And with that, I think we'll open it up for questions and I'll hand it over back to Andy.
Okay, thank you so much, Dr. Lieu. Give me just a moment while I pull up the slide here. Here we go. So we do have a couple questions that have come through. Let's go ahead and get started. And just a reminder to the listeners on the line, if you do have a question, you can type it in on the right hand of your screen. And we will get to your questions. So the first question, can you speak to how biomarkers can be used as early detection of colorectal cancer? So not only for a treatment-oriented purpose, but also in terms of prediction.
Yes, so I'll answer that question in regards to kind of preventative and screening techniques. And so you could actually make the argument that even a fecal occult blood test, so looking for any blood in the stool, does count as a biomarker because it may, if you see blood in your stool or you're able to test for that and you get a positive test, that may actually lead you to get a colonoscopy, which could then prevent a colorectal cancer. What the question may be more leaning towards is the development of some of these tests that actually look for specific fragments of DNA that the tumor can leak into the bloodstream that may predict whether or not a cancer is present or if a cancer has recurred. And so you're actually starting to see several of these blood tests come onto the market. And what's going to be interesting to see is over time how these tests kind of perform in the general public, but you're going to actually see more and more blood tests come out looking for fragments of mutated DNA, which may signify that somebody needs to get a colonoscopy. And that technology is actually emerging and getting better, I might add. And so that's certainly something that will be coming in the future.
Great, thank you. Another question just came through, and we see this question a lot actually. Can you be tested for your biomarkers after a tumor has been removed by surgery? And if so, how long after?
Yeah, so that's a fantastic question. Most of the biomarker testing that I described is actually done on what we call archived tissue, or tissue that's already been removed. And so if you've had a colorectal cancer tumor that's been biopsied or removed, oftentimes we can use that tumor tissue in order to get mutational testing on that. And we can also do MSI testing on that as well. And so the answer is yes. There are rare instances where you may have to undergo a repeat biopsy just to get enough tumor tissue in order to do the testing. What we also know is that these biomarkers have a tendency to be consistent from the primary tumor, so where the tumor originated in the colon or the rectum, and the metastatic site. So if there's a tumor that's gone to the lung or the liver, a lot of times you actually see similar mutational profiles between the two. And so if you have a tumor that you removed several years ago from the colon, and you're wondering if that might be similar to a tumor that's developed in the liver, oftentimes they are fairly similar in terms of what their genomic profile looks like. I'll go ahead and address the other thing that is kind of emerging, and that is that sometimes these biomarkers can actually be tested through the blood. And so there are several companies and universities that are able to test for mutations from a simple blood draw. This is certainly a newer and emerging technology. A lot of times clinical trials will still demand that biomarker testing be done on the tumor, but we're probably going to get to the point where a simple blood draw may be able to tell us whether some of these mutations actually exist or not.
So that's a good segue into our next question, which I think you kind of answered. The question is, are you using liquid biopsy to test for biomarkers? And is this only done in advanced stages?
So again, there are some companies that have developed tests looking for recurrence of colorectal cancer, even in early stage colorectal cancer, and that technology is certainly evolving. In terms of late stage, it really, a lot of times we talk about doing some biomarker testing to just see if somebody might be eligible for a trial. I would say we're probably not to the point where people are willing to give up completely on testing a tumor tissue from a biopsy specimen or a surgical resection specimen. But you're actually starting to see some clinical trials come about where they're allowing blood-based testing, kind of a liquid biopsy, if you will. There's certainly some instances where just getting to the tumor and trying to biopsy maybe a tumor that's really deep in the abdomen, that there could be a lot of risk associated with that. It's in those instances that a liquid biopsy, we absolutely utilize it, because why subject somebody to the risk of a biopsy if we can just get it from the blood? The way we do things here at the University of Colorado is that we may actually do both. Try to get mutational testing done on the tumor, but also draw the blood as well.
Great, thank you. Let's see. How would biomarker status help people who have already completed their treatment?
Yeah, so I would say a lot of the biomarkers that I talked about we used in a metastatic setting, mainly because unfortunately in the curative setting, we're kind of left with chemotherapy. I say that unfortunately because we've tried some of these targeted drugs in the curative setting and they just have not panned out like they have in the metastatic setting. And so therefore, a lot of the biomarkers that I talked about, we talk about with stage 4 colorectal cancer or metastatic colorectal cancer. Having said that, if you're done with your treatment, the one-way biomarker testing may kind of alter what you do in that setting is if you have a PIK3CA mutation. And so there's a lot of data out there for the use of aspirin to prevent a second colon cancer from arising. A lot of my patients do choose to take a baby aspirin simply because it's cheap and there's very, very little risk to it. But having said that, if there's somebody that has a PIK3CA mutation, which is one of the biomarkers that I talked about, and I could tell you that, well, the existing data may suggest that we could reduce your risk of having the cancer come back by 90%. I mean, that's pretty telling. And you know, it's not a randomized controlled trial. It's not the best evidence that's available, but what evidence is out there, it may change practice. And like I said, it's just one thing if we're talking about chemotherapy, another thing if we're talking about a baby aspirin, but that would be the one instance where early stage colorectal cancer biomarker testing may be important.
Thank you. We have 2 more questions in the queue here. So again, if all of you listening have additional questions, please feel free to type them on the right-hand side of your screen. So Dr. Lieu, are there biomarkers that determine recurrence?
So, you know, one of the oldest biomarkers that we talked about even in the last couple of minutes was CEA, and we certainly use CEA, although it's not a particularly sensitive or specific biomarker. It's not the best biomarker that we have by any stretch of the imagination, but we do utilize CEA to determine whether or not we need to get a CT scan earlier. Like I said, there are some emerging technologies where they're looking for mutations in the blood that may help determine whether or not a recurrence is actually happening. There's one study with a blood-based test where they were able to show that that test was better than CEA in terms of predicting recurrence.
And the last question we have here for now, are there biomarkers associated with IBD that link with CRC biomarkers?
So biomarkers that link with IBD and may link with colorectal cancer. So at this time, no. One of the things that we know that IBD can alter is the mutational profile. With some of the biomarkers that we currently use to determine treatment or personalized treatment in a metastatic setting, they haven't necessarily been linked to IBD, but it's certainly an important research question to see if there's something particular about the mutational profile in patients that develop colorectal cancer from Crohn's or ulcerative colitis that may be similar, because the question then being, well, if there's something unique about that patient population, maybe it is an opportunity to try a particular set of drugs in that patient population. But at this time, the answer is no.
Thank you. We do have an additional couple questions that came through. Can biomarkers change over time?
So that is a matter of debate. So one of the things that we know from kind of like the older literature is that, you know, when we look, you know, I talked about this before, when you look at the primary and the metastatic site, a lot of times, particularly with KRAS and BRAF, those mutations appear similar across a metastatic site and a primary tumor. When we do some of the blood-based testing, what's interesting is that you can actually, when patients are treated with the EGFR inhibitor cetuximab or panitumumab, and you're doing, you know, kind of continuous, you know, blood draws every couple of weeks or every month in those patients, you can actually see mutations kind of appear and disappear, which is unbelievable when you think about that dynamic change. You throw a targeted drug into a tumor cell and you start seeing different mutations kind of pop up in the blood. It does suggest that there's a very dynamic process going on here, which may explain why some patients respond very well to targeted therapy and then suddenly develop resistance. And so this is a very, very good research question. I don't think that we know enough to be able to firmly guide how we use that information, but I think that we will in the future.
And a similar question about mismatch repair. So if you're MSS, are you always MSS or does that change?
Yes, as far as we know, when you're microsatellite stable, you're microsatellite stable. And a lot of this is just, it's due to either the defect in, you know, hereditary genes, and that's the Lynch syndrome, If you're MSI-high, you're just going to be MSI-high, and that's it. But then a lot of this is just the alterations that we see in the tumor. And so if you're microsatellite stable in the tumor, that tumor has the ability to repair DNA. And so that's just going to basically behave like a microsatellite stable colorectal cancer, as opposed to an MSI-high colorectal cancer, where if you really do have a defect in repairing DNA, then that's just going to continue to go, no matter how many cells you kind of grow and divide over time.
Great. Can you have different combinations of biomarkers?
Yes, that's a great question. And certainly none of these mutations exist in a vacuum. So we know that there are certain mutations that are mutually exclusive. In other words, you can't have both mutations at the same time, or at least it's extremely rare. An example of that would be if you're RAS mutated, then there's an extraordinarily low chance that you're BRAF mutated, and vice versa. But having said that, if you look at the other kind of gene that we talked about, PIK3CA, you can have a combination of a RAS mutation and a PIK3CA mutation, or a BRAF mutation and a PIK3CA mutation. So, and that's the thing, that's what makes, you think about all the genes that we test for, and there are different combinations of these genes that can be mutated and coexist together. It just means that you can have a number of combinations, mutations, all making these tumors very, very different. And that's why the more we kind of are able to learn about biomarkers, the more we'll be able to personalize treatment for each patient.
So I know we already spoke a bit about recurrence, but are there any biomarkers that can monitor the aggressiveness of a late-stage colon or rectal cancer?
Yeah, the most common one that we use to determine aggressiveness really is BRAF. That seems to be one of the most kind of prognostic or kind of aggressive types of colorectal cancer. The reason why we feel like it's important to know whether somebody has that mutation is because maybe we can intervene earlier with a clinical trial. And again, there is obviously promising clinical trial results with the trial that was presented at ASCO this year. But that's probably the most common one that we test for to determine aggressiveness.
And we have a couple more, Dr. Lieu. Thank you so much. What are good opportunities for MSS and combination strategies? So MSS patients,
Yeah. So with as exciting as the immune therapy data has been, again, it's really only 4 to 5% of the patient population, so you're kind of left with the other 95%. So which means that all the data that I showed you in terms of biomarkers would really apply to patients that have microsatellite stable colorectal cancer. And so all the things that have honestly worked very well and have improved the treatment of colorectal cancer certainly applies to microsatellite stable colorectal cancer. Oftentimes this is a combination of chemotherapy and targeted therapy. Certainly keeping things very vague, on purpose, because every patient is certainly different. But it also means that most of the clinical trials that are currently available for metastatic colorectal cancer are enrolling patients with microsatellite stable colorectal cancer.
Great. And our final question for the afternoon: are there trends of biomarker type for younger patients versus older patients?
Yeah, so that's actually another fantastic question, and one that I wish I had a more kind of firm answer. We've actually done some research here at the University of Colorado, comparing older patients' tumors to younger patients' tumors, and we do see some subtle differences. We know that certain mutations are more common in older versus younger. A great example of that would be the BRAF mutation is oftentimes seen in older patients as compared to younger patients. We know that there are certain mutations that are more prevalent in younger patients compared to older patients. And so the answer is there does appear to be not gigantic major differences, but there are subtle differences between younger and older patients. And that's certainly an area of research that we have here, because the question being, if we can identify those differences, does that mean that we might be able to offer a better personalized treatment for our younger population with colorectal cancer? And so I would say stay tuned to be determined.
Great. Well, thank you so much, Dr. Lieu, for a wonderful presentation and for answering all of our questions for the day. And for all the listeners, thank you for tuning in. This webinar will be posted on our website by early tomorrow morning. So if you missed it or would like to rewatch, you can find it at fightcrc.org. And again, thank you, Dr. Lieu, so much for your time today.
Well, thank you for the kind invitation, and thank you everybody for taking time out of your afternoon to be here.
Great. Thank you. Bye.